OSCEs don't have to be overwhelming. They should be enjoyable and a way to demonstrate to the examiner that you have worked really hard and you know what you are doing. As an OSCE examiner, I see many common mistakes that can be easily avoided. I have 2 videos you can watch which will help you do amazingly in your exams. This video is part of an OSCE series which will help you tackle various topics across specialties. In this first video in the series, we'll be looking at urinary incontinence and prolapse. Perfect if you are currently on an obstetric and gynaecology rotation or need to revise this topic for your up and coming exams. Hi everyone and welcome back. Welcome to a new OSCE series on the channel. This series is in partnership with AnatomyStuff. They produce a wide range of anatomical models and posters perfect for you as a student, but also for doctors in training and general practitioners like myself. AnatomyStuff are the UK's leading medical education supplier and have served the NHS, universities and professionals for over 20 years. From anatomical models, charts, clinical task trainers and patient simulators, they have over 4,000 products to choose from. They even have a free resources area with hundreds of free evidence-based resources to learn and teach anatomy, pathology, clinical skills and healthy lifestyles. You can explore videos, articles, digital downloads and more. You can check out their website and a discount code in the box below this video for 30% off this anatomical chart, and the offer lasts for 1 month. As always, if you enjoyed the video, then give it a thumbs up and be sure to subscribe to the channel for more of the same. The video will be broken down into the anatomy of the pelvis using this amazing model by AnatomyStuff, the assessment of urinary incontinence and prolapse, including the type and severity of urinary incontinence, and we will just focus on one type today, causes and contributing factors, complications, and then the management including examination and treatment. So let's talk about the anatomy of the female pelvis. So there are 3 bones of the pelvis and some key bony landmarks. The pelvic inlet. The female pelvis is circular versus the heart-shaped in men. Posterior aspect is S1 plus each side of S1, the alae or wings. Lateral side is the prominent rim of the pelvic bone. Anterior aspect, pubic symphysis, 2 pelvic bones join in the midline. Pelvic walls, 2 important ligaments connecting each pelvic bone to the sacrum and coccyx. Sacrospinous and sacrotuberous ligaments. Pelvic outlet, so the anterior portion is the pubic symphysis, which is a secondary cartilaginous joint, which is a wedge-shaped fibrocartilaginous disc between 2 layers of hyaline cartilage towards the ischial tuberosity. The posterior aspect is the sacrotuberous ligament towards the coccyx and sacrum. Pelvic floor separates the pelvic cavity from the perineum, which is a thin layer of skin or a space between the vagina or vulva in females and the scrotum in males, and the anus. The vata ani, iliococcygeus and pubococcygeus, 2 muscles of the puborectalis, they join together, and the coccygeus muscle is basically the pelvic diaphragm when they overlie the sacrospinous ligament and pass between the sacrum and coccyx and the ischial spine. We're now going to talk about the various types of urinary incontinence. But what is incontinence? The International Continence Society defined incontinence as the complaint of any involuntary urinary leakage. NICE Guidance 2019 details the main types as stress, so involuntary leakage on effort or exertion when sneezing or coughing, and we will be focusing on this type of incontinence in the video. Urgency, so involuntary leakage associated with or occurring before the sudden compelling desire to urinate, which is described as urgency, and this is part of the overactive bladder syndrome. So that's basically urgency associated with frequency and nocturia. This can be divided into wet and dry, where the patient may or may not suffer with incontinence respectively. Mixed, so stress and urgency symptoms. Overflow incontinence, so this may be caused by A, detrusor underactivity. So detrusor is a muscle which contracts and relaxes to release and help store urine respectively. Or B, bladder outlet obstruction, which means the bladder is unable to empty fully, therefore leading to the retention and then leakage of urine, chronic urinary retention. Continuous urinary incontinence, so this might be caused by a fistula, which is basically a connection between two body parts where there shouldn't be one. For example, between the anal canal and the vagina, and the severity of their condition. You should also be aware of a urethral diverticulum, which is rare. This is a pocket or outpouching which forms next to the urethra. Situational, so depending on the situation, for example, laughing or intercourse. In order to distinguish between the above types during your history taking, you should ask the following questions. Do you notice any leakage or urine when coughing, sneezing, or when exerting yourself? And this would indicate stress incontinence. Do you feel the urge to rush to the toilet, which is urge and overactive bladder syndrome? Do you need to use the toilet or pass urine frequently throughout the day? So urge and overactive bladder. Do you have to get up at night to pass urine? Urge and overactive bladder. If the patient's symptoms seem to be a mixture of the above, so roughly an equal amount of urgency and stress incontinence, then this is likely to be mixed incontinence. If symptoms occur without physical activity or a sense to rush to the toilet or urgency, then it's unlikely to be stress or urgency incontinence. If this is the case, then you should ask the following. Do you feel you have to strain to empty your bladder? Or do you feel as though you have not finished passing urine when you go to the toilet? And this will be indicative of overflow incontinence. Do you feel that you are constantly leaking urine? This could be a fistula, for example, a vesicovaginal fistula. Do you notice dribbling or pain when passing urine? Do you have recurrent urine infections? Do you have abnormal vaginal discharge? Or do you have pain before, during, and after sex or sexual intercourse? And this will be indicative of a urethral diverticulum. So in order to determine how severe the urinary incontinence is, you should consider the following. How often does the patient suffer with incontinence? When does it occur? If she has identified a pattern. And is it associated with any particular activities or movements? Does the patient need to use incontinence pads? There are different sizes, so don't forget to ask about this too. And how often does she change the pads or have to change her clothing? How often does the patient pass urine during the day and at night? Other questions to determine the cause and any contributing factors would be, do you drink caffeine or coffee and tea, alcohol? And if you do, how much? Obstetric and gynaecology history and a sexual history are important. Red flags such as hematuria or blood in the urine, ongoing bladder or urethral pain, recurrent UTIs, constant leakage which might suggest a fistula. Their past medical history will include medical conditions such as heart failure, diabetes, any neurological conditions that could cause incontinence such as spinal cord injury, multiple sclerosis and Parkinson's disease, previous investigations or treatment for urinary tract issues, and previous surgeries such as spinal surgery. Medication history, so are you taking any regular medications and importantly over-the-counter medications, and of course recreational drugs. There is a long list of medications that can cause or even exacerbate symptoms, but a few examples to consider would be alpha-1 adrenoceptor antagonists such as doxazosine, antidepressants, diuretics, hormone replacement therapy, benzodiazepines. Management. So in terms of examination, you should always start with a general and then a closer inspection of the patient. You might want to look at the patient's weight and body habitus and if there are any signs of neurological disease. You'd want to perform an abdominal examination for a palpable bladder, which as we've seen could be due to chronic urinary retention, or a mass, which could be cancer or fibroids, and complete it as you normally would. Then you want to do a pelvic examination. So you should inspect for any skin changes, for example, signs of atrophic vaginitis, masses, so it could be a prolapse, which is basically a bulge at the vagina, diverticulum, which is a sac-like protrusion between the periurethral tissues and anterior vaginal wall. Ask the patient to cough and look at the urethral opening or meatus to see if there is any leakage or urine, which could indicate stress incontinence. You'd want to do a bimanual examination where you basically insert 2 fingers into the patient's vagina to palpate the cervix and the ovaries. You ask the patient to squeeze your fingers like they are trying to hold their urine. And this would be to check for muscle tone and contraction. This can be assessed using the modified Oxford grading system. So you can assess the strength of the contraction. 0 is no contraction at all, 1 is a flicker, 2 is very weak, 3 is moderate, 4 is good, and 5 is strong. A bedside test that you could perform would be a urine dipstick test looking for evidence of a urinary tract infection. So you would see leukocytes and nitrites, for example. You'd want to mention to the examiner that you would send a midstream urine or MSU sample for culture whilst treating with antibiotics if you thought the patient had a urine infection. Complications. So depending on this scenario, you could also consider the following. Renal function. So this will be to look for acute kidney injury or AKI if you suspect urinary obstruction. Assess for depression and quality of life, as this could be significantly affecting the patient's quality of life and their mood. Asking about insomnia, if there are frequent trips to the toilet at night. And what about an assessment of mobility or their risk of falling and potential fractures? You should also ask about the family or carers, because this could be affecting them too, and if so, how? So in terms of treatment, you could ask the patient to keep a bladder diary, and NICE suggests keeping a diary for 3 days at minimum, and this should include a variation in what the patient does each day, so you can understand different types of activities that the patient does, for example exercises or their working pattern. You also want to address any causes or contributing factors as above. You want to discuss lifestyle advice, so reducing caffeine, fluids, their weight and smoking cessation if applicable. You also want to provide sources of support and further information, such as the NHS website. The patient can be referred for a trial of 3 months minimum supervised pelvic floor training. So this can be with a continence advisor or nurse specialist in urogynecology or a physiotherapist specializing in women's health. The guidance is a minimum of 8 pelvic floor muscle contractions at least 3 times a day. Now, NICE does not recommend things like absorbent containment products, toileting aids, unless there are certain circumstances such as whilst waiting for assessment or having ongoing treatment and for long-term management, but only after other options have been considered or tried. If the above do not work, then you might consider a referral to urogyne or gynae or urology for surgical procedures. Or the woman can be offered duloxetine, which is a type of antidepressant. This is if she doesn't want to consider surgery or is not suitable for surgery. So that is a summary of urinary incontinence and a small bit about prolapse. Don't forget to head over to AnatomyStuff's website. I will put a link in the box below the video. There is a 30% discount on the poster, which is very useful. As always, if you enjoyed the video, then give it a thumbs up and be sure to subscribe to the channel for more of the same.